So quickly invite
Yeah,
Professor Vanathi.
yeah.
She'll be taking us through the pediatric keratoplasty steps and intraoperative challenges. Thank you.
Thank you, Murli, and I'm really so happy for attending this course in the morning because all the earlier talks still add on to what we are learning in pediatric cornea. And I think our understanding is still evolving, and this is one of the most challenging scenarios we are managing as pediatric corneal surgeons here. Have no financial interest in the mention of anything during the course of my talk. Considering this is catering to pediatric, I think developmental anomalies was the title of this instruction I see. So I'm just probably sharing three pediatric corneal opacity cases so that we can probably discuss the highlights pertaining to those cases here. So here you're looking at a congenital corneal opacity here, which is, as we would all have looked at, we would have called it Peters very easily here, but you look, the limbus is not looking normal, the iris is also not looking normal here, and we do have a particular, I think this also had an operated glaucoma in this particular patient here. So we'll go back to what we are probably looking at in terms of redefining the classification of congenital corneal opacities in these cases. So we have probably moved on, or there is an onus to redefine these cases as from what we thought of traditional Peters type 1, type 2, type 3 to now they talk about KID and KILD, KID or KILD, so which is keratoiridodysgenesis or keratoiridolenticular dysgenesis. I think both of these classifications, the way we look at it, have their own pros and cons here. So when I was a resident training in cornea, I still remember reading Kretschmer's where Peters 1 had an excellent prognosis or a better prognosis than Peters type 2 or type 3 here, where the pathology just involved the cornea and you probably had a lesser involvement of the iris or the angle or the lens in these cases here. Peters type 2 and type 3 are categorized, where type 2 you do have the iris abnormalities also involved, and the angular abnormalities probably are not that morbid here. But when you're looking at keratoiridolenticular abnormalities, you're looking at cases where you also have both the iris and the lens involved in these cases here. And this was helpful in prognosticating and how the glaucoma behaved in these particular cases here. So that really helped our understanding vis-a-vis looking at just as KID and KILD. But when you're looking at just KID cases, then these are cases where you pretty much, your prognosis is perhaps much better because your glaucoma is less severe in these cases. But when they move on into a keratoiridodysgenesis and iridolenticular dysgenesis, the glaucoma is more severe to treat, or if they didn't have glaucoma to begin with, they do invariably develop glaucoma during the course, or probably that was not picked up earlier on during the surgery. I still do not use a Fleringa ring in these patients here. I know Dr. Radhika always uses Fleringa in her rings, but I find it much easier not using. So that's one aspect in pediatric keratoplasty. It is always better to learn to train with using your Fleringa rings here. So here you've got a suction trifine. You've triphined it on here, so I still would like to do it without the posterior ledge, but I do land up getting a posterior ledge in there. So once you've opened up, you see the iris is anomalous here. The pupillary margins are also anomalous, but the angle recesses are pretty much okay in these cases. So these cases are otherwise behave like pretty much a conventional pediatric keratoplasty, which you would do probably for a CHED or for a PPCD or for any other acquired corneal blindness cases here. So this is a straightforward keratoplasty case, and what you probably worry is managing the glaucoma in these particular cases here. So in the interest of time, I think I will go on to the next video here. I'm sorry about this because my disk got corrupted when it was loading on the system there, and I had to reassemble this, and I didn't realize it got corrupted until I looked at it this morning. So this is particularly what I think I also concur with. I saw a similar presentation from Murli in one of the earlier presentations here. So I completely agree with what Dr. Sushmita was sharing with us, and I think it was like she was just wording my thoughts here. And when you see these intrastromal clefts here, and these invariably have the iridolenticular adhesions here, and as long as the lenticular adhesions are not there, it's conio-irido adhesions, and they have these clefts. These cases do not do so well with their keratoplasty. They do have angle anomalies abnormal. The limbus does not look normal here, and you are also seeing that you have an anterior insertion of the conjunctiva over here, and this is pretty much a very small cornea, and I'm still wondering what I would choose in terms of the corneal diameter for my for performing or proceeding with the keratoplasty in these cases here. So I've also seen Murli do this, where you sort of recede the conjunctiva a little posterior here, and you try to fix it out there. And I did try this in, I think, 2 cases, but I think I will look forward to Murli's advice on how it really works, and it really did not help much. This, otherwise you could see that the iris is looking anomalous here. The lens is not involved in this particular case, and there is a dilemma whether you would probably call these patients as partial sclerocornea, or you would just call them a variant of Peters here. But I think the new classification is here comes to help. They just say it is anterior segment developmental anomalies here. So you go ahead and finish the surgery for this patient. But the problem which I had with this, there was a persistent epithelial defect which was not healing, and it came up with all the other problems and resulted in a graft failure for this particular patient here. So that's one other scenario which I had in this condition, and that's another problem which we will have to worry about when we are managing these cases here. So this is the third video here before I finish here, and here you look at what again Sushmita was showing. You have this central clearing which appears well here, and an anterior segment OCT imaging helps in these particular cases when you could probably look at how this center one is behaving. I think I didn't have the imaging video incorporated onto this. It was separate. Again, proceeded on to do a keratoplasty for these corneas, are particularly small, deciding on the diameters for these cornea, and deciding whether they did have a pre-existing glaucoma which was missed because of the imaging difficulties, and because of picking up glaucoma in these patients is a concern here. As long as the lens is not touching, then it's pretty much okay, and you'll end up doing a conventional keratoplasty. But the challenge lies here in these cases is as much as the difficult procedure, it's also managing the postoperative problems, the persistent epithelial defects, because the limbus tends to be anomalous. Estimating the postoperative pressures in these cases, and what is the right procedure, what is the timing to deal with the glaucoma in these patients, what are the medications you need to give for glaucoma these patients, and if you cross these hurdles, the immunization, cross-reacting or crossing roads with the with graft rejection here, and that's complicating. And as was rightly pointed out earlier, these are eyes which do not have much vision here. So most of these parents who are coming from below poverty lines or low socioeconomic circles also do not pay particular attention that the graft is not doing well, and that's one of the reasons why they tend to report to us later here. So here we have multiple problems on our hands, but it is better to recognize that simple kids keratoiridodysgenesis without intrastromal clefts perhaps do better in terms of keratoplasty. And when you have an extensive kid, very severe keratoiridal adhesions or keratoiridolenticular adhesions, these corneas do not do well, and I am now started rethinking and counseling the patients when I am offering keratoplasty as a trial of giving whatever plausible vision these eyes can have. I think I'll stop here, and thank you for your patient hearing.
Thank you. There are nice invaluable intraoperative tips. Are there any questions to
So one question is, when you see, I'm still calling it Peters anomaly until you come out with the accepted international classification, or what to call them.
It is accepted. It is accepted and published as well. The Ken Nistel's group is the one who strongly advocates this newer classification of primary.
I thought you all had your meeting just now about the international classification.
Unfortunately, I couldn't attend, and then that it was a pre-conference meeting.
What I was asking was, what is your experience of the posterior Descemet's defect in Peters anomaly? Because we very rarely see the iridocorneal adhesion or the lenticular one. Those are really rare.
Yeah.
Most of ours are the Descemet's defects or the Descemet's and stromal defects. But since they come to me, they're all with glaucoma. So I'm looking for a cornea perspective. Do you see
So yes,
more of
yes,
these?
there are variants of simple Peters type 1. This is what we usually conventionally called as Peters type 1, and I also prefer calling them Peters type 1 here because they have the best prognosis in terms of keratoplasty and also in terms of glaucoma management in these cases here. But then this intrastromal clefts and this variability in the density of the opacity which you see in the central cornea does tend to happen. And when I see this variability, there is also a limbal anomaly in there, and they sort of cross with what we used to call as a sclerocornea. Whether it is a partial sclerocornea, some part of your peripheral cornea is also, your limbus is also involved. In those cases, your keratoplasty doesn't do well. If it's just a simple posterior stromal excavation defect, then they tend to do well. Without glaucoma, they tend to do well in terms of keratoplasty. I'm still talking about it with the perspective of how the graft does well, and I think the glaucoma takes a back seat for me. But then invariably it is always the glaucoma which sort of complicates the prognosis of our grafts.
We have a little over 80% 10-year graft survival for the type 1 Peters, whereas the type 2
Without glaucoma. That's my question.
My type 2s or the keratoiridogenesis, sometimes I feel so sad to see the graft growing, start the opacification or the failure starts as early as 3 to 4 weeks post-op. By the time I'm doing my second examination under anesthesia, the graft is already gone, the sutures are loose, otherwise they have persistent epithelial defects, and even if they do, they cross the 3 months, they don't cross the 6 months.
What do you call the type 1 Peters? Without the
It's KID. No, if there's no iris, then we just say it congenital corneal opacity. But the classification which Ken Nischel's group gives is that the primary ones, that's
iridocorneal abnormality.
Yes.
Iridocorneal-lenticular abnormality. He wants to call that as a spectrum, not a Peters.
Dr. Vanathi, are you able to see these clefts on handheld slit lamp?
It's very difficult to examine these children. We still haven't used a handheld slit lamp on kids because for the reason we are yet to acquire one here. We have an IOCT and we have a UBM which looks at these, so that's what we used to look at.